वाले हैं ज़्यादा ब्राइट दिखे ना वैसे लाइट कहाँ से वहाँ से कहीं एक
Hello,
फोकस
good evening, good afternoon, everyone, and welcome for today's MedTalk webinar. I am Adav Sheen, your moderator for this program. Today, we explore an exciting and challenging theme in pulmonology chess mysteries, case based adventure in pulmonary medicine. Pulmonary
तो
cases
फोटो
often
खोलने में
presents
जब
like puzzles,
टाइमिंग
and
का तो
today we
आएगा नहीं
aim
तो
to
क्या
unlock some of those mysteries together. It's an absolute honor to introduce our esteemed speaker, Professor Dr. Rajendra Prasad. Sir, let me share some of his achievements. He did MD, DTCD, FAMS, FCCP USA, FRCP Glasgow, FRCP London. He was Dr. BC Roy National Awardee also. His profession is Emeritus Professor, National Academy of Medical Sciences, India. He is Vice Chairman, National Task Force NTPEP India. He is Director, Medical Education and Professor, Respiratory Medicine. He is Eraz Lucknow Medical College Hospital former Director, VP Chest Institute, University of Delhi and UP. Rural Institute of Medical Science and Researches, he is former head pulmonary medicine KG Medical University, Lucknow chairman UP Tuberculosis Association. Sir has dedicated his career to advancing respiratory medicine in India and globally, and it is our privilege to learn from his experience today. Sir, I am hand over to you. While Dr. Prasad share his presentation, I encourage you all to share in the chat if you have ever faced similar diagnostic challenges. Your experience can help enrich this discussion. So we are eager to hear your insights on these. The stage is yours now, sir.
so am I audible? Hello.
Yes, sir, you are audible. Now you can continue.
No, am I audible?
Yes, sir, audible.
So my
You can start.
photograph will not be here.
Yeah, yeah.
My
Sir, it
slides are
is visible.
visible.
Yeah,
Huh?
yeah, it is visible, sir. You are also visible and your presentation is also visible. You can continue, sir.
But
Thank you,
on
sir.
my laptop, I am not. My face is not visible.
No, sir, it is visible. It's not an issue, sir.
Okay, not an issue. Okay,
You can continue.
continue.
I can
So
see you, sir.
okay. So good afternoon, and at the onset, I wish to thank the organizer for giving me this opportunity to share just mysteries of case-based adventure in pulmonary medicine. So what I will do in this about half an hour, I'll share you some of the interesting cases which is very important in day-to-day clinical practice. These are my institute where I have worked. My whole life I spent in King George Medical University, Lucknow, which is one of the premier medical universities of the country. After serving about 41 years in KGMC, I moved as a director, UP Rural Institute of Medical Sciences, FAE. And finally, I worked as a director, Vallabhbhai Patel Chest Institute, Delhi. After my superannuation from Patel Chest, I am currently working in Eras Lucknow Medical College and Hospital. I start with my any lecture with this uh, slide that many people ask us uh, how you have become like this. So I follow this gentleman, and he says, if you want to shine like a sun, firstborn like son. So what I'm trying to say, you have to be very hardworking if you want to sign. And you have seen APJ Abdul Kalam, the same thing. And initially, my good luck that I worked in Japan way back in 1989. You can see my photograph at a younger age. So, uh, and this is the Tokyo Disneyland. And then I worked in a hospital which changed my career. And there I learned again a proverb that better than 1,000 days of diligent study is one day with a great teacher. I'm not saying that I'm a great teacher, but I said these words for my mentors. My mentors have been great, and I always remember before taking any lecture. In KGMC, one of my mentor was Professor B.K. Khanna, who is no more, apart so many others. At the national level, there have been so many mentors. And I would like to start. This is one of my YouTube lectures. I think many of you will be interested. This is the chest X-ray interpretation. Being a pulmonologist, chest X-ray is very important for us. So interpretation for UG student in Hindi. This is one of my YouTube lectures, which I think by now must have been observed by about 3,70,000 people. And then we had some of the cases what we are sharing have been given in this book, which I wrote 100 cases in pulmonary medicine. And then we have book on allergy, and we have book on chest X-ray even in 2 volumes. And this book was released by very recently by Deputy CM of the state of Uttar Pradesh. And these books are all available on Amazon. If anybody is interested, you can go ahead. Now I'll start with this X-ray, a pearl, I must say. When you see this X-ray, I read it carefully. So it appears that there's a cardiomegaly. Heart size is increased. But I always say that when you read chest X-ray, you must see the technical points also. And when we have studied technical points in this, the both the dome of diaphragms are higher up because the film was taken in expiratory phase. And ideally, chest X-ray should be taken in inspiratory phase. So, realizing this, that this film is expiratory, so they may not be cardiomegaly because clinical examination revealed nothing. So when you know when the inspiratory film was done on the same patient, diaphragm has come down, and even heart size has become normal. So what I'm trying to say that when you read for any case, when you read chest X-ray, or if for that CT scan, you have to be very careful whether the films have been done properly or not. So this was inspiratory film of the same patient. And even it is true in CT scan. This CT I am showing to you, if you see, CT initially shows, you see the trachea shape, CT is again done in expiratory phase. Although there are indications for expiratory CT scans, but ideally CT scans should also be done in a full inspiration. But because of the trachea, this was clear that, but this case was unfortunately referred to me as a diagnosis, or there are multiple bilateral diffuse shadows as a case of interstitial lung disease. And even lower cuts have shown all the shadows. But when the film was done in a full, now you can see the shape of trachea. Now this is a full shape of, this is inspiratory film. So all those shadows which were present in the previous same person CT has disappeared. So what I'm trying to say that quality of the X-ray or CT before you read it, before you try to diagnose, because chest medicine always you do order CT or chest X-rays, and there you have to be very careful that their quality of the CT or chest X-ray is very important. With little bit of this earlier introduction, I will show you a case. I'll start with a case. He was about a 20-year male. I saw him way back in 80s. And at that time, he had complaints of breathlessness for 10 years, fever for 2 months, cough for 2 months, and hemoptysis for 15 days. You know, hemoptysis is in India is taken as synonymous for tuberculosis. But I always say that reverse is not true. Not every case of hemoptysis will have tuberculosis. Now, with this background history, let us see this case. This case came, first X-ray I have of this patient in 83, which many of you will agree that it is looking like a consolidation on the right side. So, but the history is fever is of very mild nature. History is not like consolidation. And then he has got history of breathlessness for last 10 years. So probably he was a known case of asthma. And with the asthma background, what we saw that there's a consolidation. Somebody rose antibiotics, he received even anti-tuberculous drug many times. But let us see what this case was. A very interesting case. And you know that after some time, I'll disclose you treatment later on. After about 2 months of treatment, you know the shadows has disappeared. Believe me, it was not antibiotics. Then in subsequent follow-up, 84, the what shadow was there on the right side, the similar type of shadows has appeared on the left upper jaw. Again, consolidation like shadow. Subsequently, even that disappeared, and in 80 again, the shadow has moved here in the left middle zone. Similar shadow. Then in 91, we are following here for last 40 years, and 91, what he said, shadow has moved here, and even some small cavitation. Again, he was diagnosed as tuberculosis. And somebody has diagnosed as tuberculosis. And then even that shadow you find has disappeared in about 6 weeks' time. And again in 93, similar type of shadow, what we saw in 83, this is a follow-up of same patient. And then again disappeared and reappeared at another place, again in left lower jaw. And so I had published this case, and I named, to me it looks like the pneumonia is walking at each and every area of lungs. So I named it as walking pneumonia. This is also known as fleeting shadows. Shadows is fleeting. And in chest medicine, with this type of shadow, let us see what we have diagnosed. So this was the publication, Walking Pneumonia in Patients of Bronchial Asthma. As a clue to diagnosis of ABPA is allergic bronchopulmonary aspergillosis. This condition is actually allergy to fungus. And what we investigated, we did with TLC, DLC, only one pointer for this condition was eosinophil was little high. I know in India, lot of misuse of heterogen diethyl carbamazine because of the eosinophil count. But there are n numbers of eosinophilic lung condition, and one of them is ABPA. AAC was about more than 1,000. Mantux was negative. AFB was negative. Even culture for MTB was negative. Fungus culture was positive, and it was Aspergillus fumigatus. We did a skin test against the Aspergillus fumigatus, and tests were all positive. Type 1 and even type 3 reaction is when we read type 1 reaction, we read when we do skin prick test, we read type 1 reaction in 15 to 20 minutes, and type 3 reaction we read in about 4 to 6 hours. So both type 1 and type 3 were positive. In those days, we were very fond of doing bronchographies, and now bronchography is obsolete because CT scan is available. So bronchography we did, and it shows bronchiectasis, and that word is actually the proximal bronchiectasis usually present in the periphery, but here in this case, this is the proximal one. And this is the lateral view of the same patient. And 2000 in 80s there was no CT scan in even in KGMC where I have worked. But when CT scan came, we got a CT scan done. We see the clear-cut bronchiectatic shadows bilaterally present. So you can see that these are the evidence of central bronchiectasis. So clearly you see in all the three cuts we see a lot of bronchiectatic bilateral. So wherever the shadows has been there are the bronchiectatic changes. So ultimately we diagnose this condition as allergic bronchopulmonary asthma. I will let you know in a due course of time what this condition is and how it is treated. And there's another case I'm going to share with you. He was about 22-year male, non-smoker. Again, history was cough with episodic breathlessness for 7 years. Only problem he rose was recurrent streaking, hemoptysis, small amount of hemoptysis, 6 months, and loss of appetite, weakness, took many treatment, bronchodilators, even steroids, and lastly he was prescribed anti-TB drug for about 6 months. And on the examination, there was a rhonchi, suggestive of diagnosis of asthma. One thing is very clear. Other systemic examination was within normal limit. And this was the X-ray. And I don't think when there was a rhonchi and this was the shadow, some other physician, when he went earlier, he came to me later, and I'll show you when he came to me. So if because of these shadows here and here, somebody prescribed anti-TB drug only because he had a recurrent streaking. And when he completed 6 months of anti-TB drug, you see the shadows has increased. You'll agree with me that after 6 months of regular ATT, way back in 2004, shadows has increased. So doctor treating him has suspected some drug-resistant TB, especially the MD. You can compare. This was when ATT was started, and after 6 months of ATT, these shadows has progressed. If these two X-rays are shown to me, even I will say that if it is tuberculosis, it may be a drug-resistant tuberculosis because he took the drug. He was very educated person. He took the drug very, very regularly. But then he was actually previous treating doctor suspected him as a case of MDR TB by local treating physician and was referred to me. He was very smart. So before starting the treatment for MDR TB, and MDR TB treatment is difficult also. So he referred to me for further management. that is at this stage I came into the picture. So, what I'm trying to say, when he came to me, when I saw the X-ray, I took the history in detail, and we did Mantoux was though 13 mm. Mantoux only tells you the person is infected. It cannot tell you whether to. sputum, but the sputum was negative. What I thought, if there is such an extensive lesion, sputum, those days gene expert was not available. So sputum must be positive, but it was came out to that alerted me that this is something else. And then you see here also pointer is eosinophil count 30%. I have already said a lot of misuse of diethyl carbamazine I have seen. PFT also was done and shows an obstructive airway disease, suggesting of bronchial asthma. And skin test I have shown you in previous case. Skin test was done against Aspergillus fumigatus, a fungus, and type 1 12 mm and type 3, though both were positive. Again, in this case, the skin tests were positive. And then we did CT scan, and CT scan again you show some consolidation and with all bronchiectatic changes, what you have seen in the previous patient also. So that was again a sort of a proximal bronchiectasis. So other investigations we did for ABPA, total IG was in tune of 34,000. IgE against, whether skin test was also positive, and specific IgE against Aspergillus fumigatus was also highly positive. Normal is point less than 0.38 and it was 21. And IgG against, as these are the common investigation for ABPA. IgG against Aspergillus fumigatus was 118 as against the normal of less than 8. So these all tests were positive. And then we diagnose again this case not as tuberculosis but allergic bronchopulmonary aspergillosis. And when we give the proper treatment, I'll discuss later on what is the treatment of ABPA. So what 6 months of ATT could not do it. About 6 weeks of treatment has made all the difference. So what I'm trying to say that if you properly work up a case, diagnose properly, it will be rewarded to you. So again, there's another. I think this is a case, another case which I saw very recently. Again, 24-year female and complaining of cough, breathlessness, sneezing, rhinorrhea since childhood. Now, history is very suggestive that patient has a background of a probably bronchial asthma, allergic condition, and history of recurrent chest infection. Symptoms aggravates in winter. That was the history of this young lady. And this is the X-ray done in, this is the January 24. So where you find there are a bilateral shadows. Somebody diagnosed her as possible tuberculosis and sent to me for further investigation. So when I saw this lady, very thin built lady, BMI was around 15, 16. So I also suspected that this could be tuberculosis because bilateral shadows, and because of this, because of his weakness, loss of appetite. And so probably these are the differential diagnoses which came to my mind. Pulmonary TB, yes, at the top, bilateral shadows. It could be interstitial lung disease, but in young age, interstitial lung disease is not very common. And it could be bronchial asthma, as history suggestive, it could be bronchiectasis can be there, and bronchial asthma. So these are the 5 probable differential diagnoses we thought in this young lady. And with this thinking, we investigated the lady. And what should be, usual investigation in respiratory or chest medicine? You perform sputum for AFB, sputum CB-NAT, now it is available. Gene expert, what you call a true NAT, you can do CBC, you can do bronchoscopy, you can do CT thorax, PFTs, total IG. We actually planned these investigation for this lady. And sputum for AFB was negative. TrueNat was, means CBNat was also MTB not detected. In CBC, one thing was positive, that eosinophil was 8%. Same case. Now we are going in the same direction. Eosinophil is 8%, more than normal. And then this is the PFT what we did, and that clearly shows that there is evidence of airway obstruction. And this is the CT scan now, the same injury. CTs, when I saw the CT, I was alerted. Because of, again, you see, there are bronchiectatic changes. That too, usually bronchiectasis is in the periphery. But these, as I have shown you the two other cases, here the bronchiectasis was in the proximal area. Same thing is here, and all you see studied with bronchiectatic changes. And this is another view. And what again we thought it could be ABPA, so we did total serum IG, which was more than 2,500. Specific IG, again shown in the previous case, will highly positive 130, and specific IG against Aspergillus fumigatus was 45. So all the tests were positive. So what is diagnosis? So which we diagnose again this very unusual presentation, bilateral shadows of, but history is very suggestive. One thing that sees a case of asthma, and on the background of asthma, this could be one of the possibility. So ultimately, she was diagnosed. Now I would like to tell you what is this. We have shown you 3 cases of ABPA. Allergic bronchopulmonary aspergillus. What is ABP actually? ABPA, you know that it's an, if you see that the pulmonary manifestation of of Aspergillus fumigatus, say fungus, is it could be a saprophytic. You might have seen aspergillomas. It is a non-allergic background. If person is allergic background, means here in this case asthma from childhood, it could be allergic asthma, it could be allergic bronchopulmonary aspergillosis, even it could be hypersensitivity pneumonitis and invasive. And when fungus invades the lung, then there's invasive, like invasive aspergillosis. So there are so many conditions, and ABPA is one of condition. And I said ABPA is the allergic manifestation of Aspergillus fumigatus, or it could be other fungus also. Now, question is, what is the it's not very rare disease, but people are not diagnosing, and it is misdiagnosing to some other condition. TB is one of the very common diagnosis where I have around couple of 500 cases of ABPA in last 45 years, and I saw that about 40 to 50% cases they are misdiagnosed as tuberculosis, commonest diagnosis. So it comes into differential diagnosis, and their prevalence is not very rare. What I am trying, in Indian studies, all the Indian studies done shows it may range from 4 to 16%. So it's not very uncommon, but it is uncommonly diagnosed. And you know, in one of a study we did in KGMC when I was there, and we published in 2008, and we screened about 244 patients of bronchial asthma, and we could find that in about 18 patients, that is 7.4%, had evidence of LH. So even in our scenario, it's not very rare disease. It's a common problem. And if you see the diagnostic criteria, the first diagnostic criteria came in 97, very famous. And if we see all the 3 cases, these are the 8 diagnostic criteria to diagnose ABPA. It could be, there's a background of asthma, cystic fibrosis is not very common in India. Immediate cutaneous reactivity to aspergillus, you have seen in both the cases. Current or previous pulmonary infiltrates, you have seen all the three cases. Elevated total Ig, you have seen. Precipitin antibodies or IgG antibodies, same thing. You have seen. Peripheral blood eosinophilia, we have seen. Elevated Ig and IgG against aspirin, you have seen in all the cases. And proximal. This was originally when the diagnosed, ABPA is not a very old condition. First case of ABPA was reported by Hinsa and Murray way back in 1957. From Indian continent, the first case was reported in about 80s and 87, I believe, to be very precise. So disease is not very old. Recently, we have come to this, and I already said I have couple of um, uh, 500 cases with me for last 45 years. So again, in 2013, a group ISAM criteria, they have revised. Although literally the diagnostic criteria are same, but they have revised like this. A predisposing condition is usually asthma or cystic fibrosis, and there are essential criteria. Essential criteria, either the type 1 skin test, we have seen in all the three cases, or elevated Ig level against aspergillus flu. You have seen all the three cases. So these are the essential, and second essential criteria is total IG must be more than 1000. Now, in recent guidelines, it has been reduced to 500. I'll share you one slide. So, this is the essential criteria. So, anybody, so what on the background of asthma, if you have found that either skin test is positive or where allergic test is not possible, then we can get it done specific IgE against Aspergillus fumigatus. There are, and total IgE more than 1000. And other criteria may be 2 out of 3. One is precipitating, and this is IgG against Aspergillus fumigatus. Radiographic pulmonary opacity is consistent with IB. I have shown you all the three cases. And total eosinophil count should be more than 500. This is the lately in 2013, the criteria were, although criteria remain the same, but they were arranged in a different fashion. And I must tell you that in 2024, these criteria has again been revised, in which there is little change has happened, that aspergillus either you can get it as per the specific Ig against aspergillus fumigatus. It should be more than 0.35. Total serum Ig must be more than 500. These are the two essential criteria. Naturally, on the background of again same thing, asthma, cystic fibrosis. Even in this guideline, even in COPD cases, sometimes you can see this. Even in bronchiectasis, you can see. So these are the backgrounds. Apart from asthma and cystic, two more diseases have been added. And then essential criteria, these two I have already explained. And then the other components of the diagnosis, out of these three, only two should be there. IgG against Aspergillus fumigatus, you have seen in all the three cases. Peripheral blood eosinophilia, you have seen all the cases. May not be today, even historical, if you previous reports are there that you can take. And then the thin sex computer CT scan is very important. That actually gives you the clue, the diagnosis of allergic bronchopulmonary aspergillosis. Now, in the recent guidelines, even the sub-classification type of ABPA has been done. ABPA-S means when serology is positive and X-ray is normally, CT is normal, but the other type of like ABPA, uh, bronchiectasis. Now proximal word has been removed. Now it has come as a bronchiectasis. ABPA with mucus plug, ABPA with high attenuated ham, and ABPA with other clinical pulmonary fibrosis. So there have been little subclassification have been there, and even the molecular diagnostics has come up very fast, and it is there in the diagnosis of ABPA, especially the recombinant aspergillus F4, F6 could be very important to diagnose ABPA. And what should be the lineup? Now, that is what is ABPA. How you should treat ABPA, that is very important. And here, in all the three cases, I said some treatment. So, steroid is one of the best choice. As I said, this is not the invasive aspergillosis. So, antifungal may not be the drug of choice. Drug of choice is, since it is allergic condition, to oral steroids. Of course, you have to treat asthma also. So, inhaled steroids you may provide. Antifungals, yes, in some cases, I'll let you know. Steroids plus antifungals and effective management of asthma. So, probably this is the possible way of treating ABPA. And so, on this background, how I said steroid, there are two dose schedule. One is low dose, another is little higher dose. And steroids is used for a longer time, I must tell you. As you see in this, prednisolone 0.5 milligram per kg for 2 weeks, then on the same dose on alternate days for 6 to 8 weeks, then taper every 5 to 10 milligram every 2 weeks, and this. And so usually treatment is for 3 to 6 months, depending upon how patient is improving. And you repeat the eosinophil count, chest X-ray, and total IG. Specific IG, not total IG, in 6 to 8 week time to see the response. In regimen 2, even you can use a little higher dose of steroids. And oral steroids, I said, is the mainstay of treatment. And then of course you have to treat asthma also. So inhaled steroid per se is not useful for ABPA, but to treat asthma you have to use this additional anti-asthma treatment you have to do. What is the role of antifungal treatment? I think next 1 or 2 slides. And another point, because aspergillus is a very common, it's a ubiquitous everywhere. So what you have to do is to reduce the environmental source if it is there, especially the damp houses, bird excreta. Those you have to keep your house neat and clean, because I said aspergillus is a one fungus which is ubiquitous. Ubiquitous means it is present everywhere. That is why these shadows are coming and going, because exposure to Aspergillus fumigatus is there. Close monitoring for relapse is very important. And antifungals, I have to say in 1 or 2 lines, what is the role of antifungals in treating ABPA? I have already said that it is not an invasive aspergillosis. So role comes at number 2, not at number 1. I have already shared with the steroids, as it is allergy to fungus. Role of antifungus, there has been many studies, there has been Cochrane review for that, and what they have concluded that itraconazole is one drug which is very commonly used if it is antifungals are used. Itraconazole in stable ABPA reduces eosinophil airway inflammation, systemic immune and exacerbation, and this can be act as a potential adjunctive treatment for ABPA, or else in places where probably you cannot use steroids. Steroids are absolutely contraindicated. There you may think of using this antifungal, especially the other antifungals can be used, but most common antifungal drug used in ABPA is itraconazole. Again, it is for a longer duration, and in one of the studies, oral steroids. They have they have compared between itraconazole and prednisolone in acute stage ABPA, and they found that oral steroids were more effective than itraconazole as monotherapy. And then patient was given tablet for 8 milligram. This patient was actually was treated with steroids, and you do the what was the bilateral extensive last case when I shown you bilateral extensive diffuse parenchymal shadows, and this was the CT picture of the same patient. Again, you saw the CT has prompted me for diagnosis. Otherwise, chest X-ray, it was very difficult to tell what it could be. But when I saw the CT, again, I see the central bronchiectasis. That prompted me to think and got all investigation done, and every investigation was positive. And a follow-up of such cases can be done usually by physical history, physical examination, chest X-ray, and eosinophil count and total serum Ig is usually done for the follow-up. Specific Ig and specific Ig is not done for the follow-up, and usually if the Ig declines by about 30 to 35%, you may say that patient, otherwise patient respond dramatically. If you really diagnose well, and so I have come to end of my presentation, and I have I have to give some take home messages, and take home messages for everybody who is practicing, whether they're either in general practice or a physician or a chest physician. These take home messages are very important. And I usually say that whatever I have learned about this disease in last more than 45 years, as I saw the first case I saw in 80s, so already 45 years have elapsed. And early diagnosis and appropriate treatment of this condition is very important. And your suspicion should be very high. And what I said that uh, if you don't diagnose early, you, you can, if you diagnose early, you can prevent lung damage, fibrosis, worsening of asthma, misdiagnosis of pulmonary TB. If you really diagnose, as I shared with you, about 40% of the patient of ABPA, they receive anti-TB treatment. That's not proper. So ultimately, if you don't diagnose, if you diagnose very late, there could be lot of problem. I have seen 3 deaths in my 45 year of career because extensive fibrosis, carpal nail, and died because they were not diagnosed properly. So initial diagnosis, I say, is very initial suspicion and diagnosis. Believe me, when we started working on ABPA, these tests were not available in the market. We used to get it done from some scientific labs. So, but now we are happy that all these tests are available in the market, and it can be done very easily. And the second take home message is all patients, I usually say, now rule also says all patients of bronchial asthma, especially the severe asthma, chronic asthma, should undergo aspergillus skin test. Must go. Or if skin test is not available, then you can do blood test like specific Ig against aspergillus fumigatus. In patients with aspergillus, suppose aspergillus sensitivity is positive, then further immunological studies are warranted to diagnose ABP. So, patients of asthma, first test is either you do a skin test with aspergillus, type 1 is positive, skin test is not possible, then go for a specific Ig against aspergillus. If these tests are positive, it means now you are seeing the aspergillus sensitized asthma. And in this group, the further workup is essential. And what further workup? Always I say, I have shown you all the 3, 4 cases, that specific Ig against Aspergillus fumigatus, specific IgG, skin test, and the initial, uh, the suspicion comes from TLC, DLC. Simplest investigation. I think every patient has TLC, DLC. So I made another dictum. Any asthma patients, if he has a pulmonary shadow is not essential 100%, but suppose asthma patient may have pulmonary shadows, and if in TLC, DLC you find a peripheral blood eosinophilia, initially it started with 1000, now it has come to 500, and you must suspect this condition, and further investigation is advised to confirm the diagnosis. That is what I was trying to say about this. Let me say that it's not, you have seen in my presentation, it's not the rare condition. It is commonly encountered in our day to day practice, provided you are aware about. Let me share with you the first case I saw in 80s when I was a resident in pulmonary medicine. And because we have attended seminars, we have attended lectures about ABPA, so we have some idea in our mindset that yes, ABPA could be like this. That is how first case I diagnosed in 80, and subsequently I have already shared you, we have more than 500 cases by now. So what I'm trying to say, initial suspicion is very important. And let me say, finish my lecture. I'm very fond of showing this slide that anyone who keeps learning stays young. Learning is very important in medical science. And if you keep on learning, of course, you'll become a good doctor, you become a good clinician. At the same time, you also keep yourself young, smart, what I think everybody wants today. With this, thank you very much. And once again, I thank you, IJCP, for providing me this opportunity to share some of the mysteries in the pulmonary medicine cases. If you have any questions, I love to answer. I always say it's provided I can answer them. So, may I unshare the slides,
Yeah,
madam?
so, sir, thank you so much, sir, for taking us through those fascinating case based exploration. Truly insightful, sir. We will now take a few questions from our audience, sir. Can I
Can
take?
I unshare? Can I unshare my
Yeah,
slides?
yeah, sir, I did. You can continue.
Okay,
Okay, yeah.
stop
Sir, the,
sharing.
the, the first question is, can I speak?
Yes, yes, go ahead.
Okay. The question is, how do you tailor treatment when a case doesn't fit neatly into textbook categories?
Well, I said textbook category. There are eight, usually seven, eight guidelines, seven, eight diagnostic criteria. And I usually, as a very senior teacher, I usually see that I have shown you all the three cases I am shared with that. If somebody is a background of asthma, had shadows, and usually CT is done. If CT picture shows bronchiectatic changes or some other shadows, then I really has a high suspicion, and even those tests which are sometimes is not possible to get it done. If I suspect on these grounds, then I start treating them. So the simplest thing what you require is symptom of asthma. Second, if X-ray there is some shadows, and third, TLC, DLC. If I say eosinophil count is between 5 to 15%, I usually say. And I have also said in this eosinophil count, I have seen lot of misuse of diethyl carbamazine. People, so please, tropical pulmonary eosinophilia where diethyl carbamazine is used, they say the absolute eosinophil count usually is more than 20%. More than 20% and more than 2,000 to 3,000. There also we use it, but not in such a mild eosinophilic condition. There are more than 200 eosinophilic conditions in the lung. So you have to argue it out, you have to diagnose, and you have to treat.
Okay. Thank you for
Yes,
the
ma'am.
answer, sir. I hope you did a justice with the answer. Now I am taking another question, sir. The question is, what are the principles of managing pulmonary overlap syndromes? Example, asthma, COPD overlap.
Okay. Asthma and COPD overlap. I agree with you. Initially, there was a condition known as matlab, asthma, COPD overlap. Now, these conditions have these terms have been removed. But only thing you have to see that if the what is the predominant one? If the predominant one is asthma, sometimes they are combined together. I agree. But if the predominant is a feature of asthma, you have to treat like asthma. And in treatment of asthma is no, the choice is inhaled steroids. But if the case is more towards COPD, so COPD role of steroid is a very limited, especially if चला गया भाई क्या? नहीं. Role of steroid is very limited in COPD, especially if the COPD patient had eosinophil count more than 300, absolute eosinophil count, then you may think of adding steroid. Otherwise, COPD is usually treated by bronchodilators. So that is how we differentiate and we treat accordingly.
Okay, sir. Thank you for the answer, sir. Now I am taking the next question, and I can see that there is a question. How do you balance empiric therapy versus waiting for confirmatory diagnosis in critical pulmonary cases, sir?
Well, I think a question is very important. What you are trying to ask from me that uh, empiric therapy versus confirmed diagnosis, especially in the respiratory cases. I'll take you example. Suppose uh, suppose you are suspecting tuberculosis anywhere in the body, and you are not being able to confirm the diagnosis by various tests, but your suspicion is very high. I'll take the example of tuberculosis. So, in this scenario, what we do and what is advised in the literature also, you can start empiric anti-TB drug. Like say somebody has Cox abdomen, where diagnosis is not very easy. Somebody has genitourinary tuberculosis, where there is a lot of, I mean, issue of the children, infertility. There also we see that if the diagnosis is even not confirmed and we see that and tuberculosis are very high, I mean suspicion of tuberculosis, but one caution I always tell my doctors or PG students that whenever you are using any entity, suppose in case of tuberculosis, we are using anti-TB drug, you must exclude other conditions. That is a very essential for empiric treatment. Suppose you have a shadow in the chest X-ray and you are suspecting it to be tuberculosis, you have not been able to prove it, so you must exclude other possible conditions. Suppose there is a shadow, it could be lung cancer also. So, suppose in the lung cancer you use empiric treatment for tuberculosis. So, realize that if you are using an empiric treatment for any disease, other common conditions which mimic that you must exclude. Then you are all right to use the empiric treatment. चला गया भैया क्या है? Yes, go ahead, madam.
Yeah, sir. Thank you for the answer, sir. And I will take only last one question is there. And the question is, what are the most common missed diagnoses in pulmonary cases and how can we avoid them?
No, no, you repeat. Your voice is breaking.
Okay,
So
okay.
repeat the
I'm repeating
question.
once again, sir. So the question is, what are the most common missed diagnoses in pulmonary cases and how can we avoid them?
No, no, still you are not audible. Your voice is breaking. Say it again.
Okay, so the question is, what are the most common misdiagnoses in pulmonary cases and how can we avoid them?
I'm sorry, your voice is still breaking, but what I understood, uh, समझ में आया भाई.
Sir, I am audible. Now is it fine?
देखिए I hope you are asking about what are the common in respiratory
Yes, sir.
system misdiagnosis. People, I must say that tuberculosis is one. Sometimes it is misdiagnosed and it is overdiagnosed many times. But if the tuberculosis, if you miss the diagnosis, you may kill the patient. So at your initial suspicion, you try to confirm it. Another misdiagnosis I have seen lung cancer. People in lung cancer, they treat for tuberculosis. And when they treat for tuberculosis for 6 months, in the meantime, lung cancer from stage 1 or stage 2, it goes to stage 4, where you cannot do anything. Lung cancer is one of the very fatal condition. So, another misdiagnosis, we see interstitial lung disease. People do not suspect early and they start anti-TB treatment or asthma treatment. I have seen many cases of ILDs where people have started anti-TB drugs, people have started asthma management, COPD management. So, it's on, and the diagnosis of ILD, I always say, it is the most easy to diagnose interstitial lung disease. What is difficult to find out what are the subtypes, but to diagnose per se the diffuse lung disease or interstitial lung disease, very simple. History of cough or breathlessness of recent onset, weeks and months time. And if you put your stethoscope or the bag, you find the inspiratory sound, especially, and if you could find a clubbing, and then this is how you diagnose ILD. But I have seen ILD misdiagnosed as tuberculosis, as asthma, very commonly.
Okay, sir. Thank you for
Okay,
the answer,
madam.
sir. Thank you for the answer, sir. I am audible. Sir, I hope you did a justice with
Hello.
the answer, sir. Sir, I am audible.
Yes, yes. Go
I
ahead.
am audible. Yeah. Sir, thank you for the answer. I hope you did a justice with the answer, sir.
Oh,
Sir, with
I
all your
can I
permission, I
give
am
you
going
one
to
more?
conclude this session. Sir?
Hello.
Yeah, sir. You are audible, sir. You can say.
Hello.
Yeah, I am audible.
Hello.
Yes, sir.
Again, you are not audible. You are not audible.
Okay, sir. With all your
I think
permission, I am
last
going to
time when I
conclude this. Yeah, yeah.
conclude, okay, go ahead. Go ahead.
Okay, sir. Sir, thank
One,
you for.
no, no, if you are
Yeah, yeah.
listening me, I have to give one suggestion to IJCP. Last
Okay,
time when
sir.
I did for IJCP, probably it was on Zoom platform, and that platform was much better than what platform you are using currently. I don't know. Eh? What is- yeah. So that's all. If you can conclude.
Thank you for the answer, sir. I am audible now.
Ajay.
I am audible now, sir.
Yes, yes.
Yeah, sir. Thank you for the answer, sir. And with all your permission, I'm going to conclude this session, sir.
So thank you very much.
Thank you, sir. I'm going to end this stream.
Okay, thank you.